Ties it. Free food.
Free lunch, you're gonna come, right? While we go to the fall fest and stuff like that, it's not for the cool bands, it's for the free food. Okay, that's what we do here. ADP, again, all you got to do is add P and it becomes ATP, which is our energy source for all cells. So by releasing ADP, it's just like releasing free food and snacks to get people to come to your party. So that's going to help attract more platelets to the area, which is going to create more serotonin release, which is going to create more ADP release. Again, that positive feedback mechanism building and building and building so we can get that clot process off the ground. They're also going to release something called platelet-derived growth factor, PDGF, and this helps maintain the integrity of blood vessels. This is similar to, applying fertilizer to your garden to make sure that your garden's nice and healthy. So as they're floating around, when they're not clotting blood, they're just releasing this factor that's going to help maintain the functionality of the cells. Because again, they're made out of endothelium, and we all remember what endothelium is, right?
Yes. It is simple squamous epithelium.
Simple squamous epithelium. That's one of those things that I drilled in A&P1. It's like, I'm going to ask that question a lot. Today was the first of many. Okay? Endothelium, simple squamous epithelium. Again, being a thin, flat cell that's only one layer thick, they get bumps, they get bruises, the cell could go down, the capillary could rupture. So by releasing this factor, it's going to maintain the health integrity of that endothelium, lessening the chance that those capillaries at the inside of those blood vessels would get roughed up, would rupture, would cause problems. So thrombopoiesis, the production of thrombocytes, again, is going to happen in the myeloid tissue where you have those megakaryocytes that basically just shed off little pieces of cytoplasm and cell membrane that are creating the platelets. So they just fragment, constantly releasing those. Yes, ma'am?
Poiesis, can it also mean formation?
Yeah.
Okay.
Yeah, production, formation of. And here's hemopoiesis in its general form. So again, you're going to have those blood stem cells one step past the mesenchyme, and then we can turn into what's going to become red blood cells with our prourethroblast going through our urethroblast, our basophilic or polychromatophilic urethroblast, or normal blast urethroblast, then our reticulocyte, then our red blood cells, then all of our white blood cells, the fills. Okay, so the granulocytes are going to come from the same progranulocyte stem cell, and we're going to stockpile our lysosomes with our little cocktails to make our basophils, eosinophils, or neutrophils. And then we've got the guys that are going to become monocytes, and then the guys that are going to become our lymphocytes. And again, some of these are T cells are going to migrate to the thymus during mid-production. And then we have the thrombocytes. So hemostasis. Hemostasis is the stoppage of blood loss, because obviously we don't want to spring a leak, because then we're not going to be able to function properly. And we have three different stages. The first one is the vascular spasm. This is basically just the blood vessel constricting when it gets damaged, just like if you stub your toe, you get away from it. Okay, so it's going to be that withdrawal reflex even at the little tiny blood vessel level. Then we have a platelet plug formation where the platelets get this form of plug. And then we have actual coagulation, a multi-step process to form a blood clot to have a permanent stoppage of that blood loss until we can heal and repair that vessel. So our vascular spasm, this is going to occur in arteries or arterioles. It does not happen in capillaries because capillaries do not have any muscles associated with them, so they can't spasm, they can't contract. Veins typically are really stretched out compared to arteries. These veins are kind of like sweatpants compared to arteries that are like skinny jeans. So whenever we look at the veins, they do have muscles, but not a whole lot. So they don't spasm as quickly, as noticeably as the arteries do. So this is going to be caused because the circular smooth muscle contracts, making that vessel smaller. So hopefully we don't lose as much fluid, and it slows down that fluid loss, giving the other steps more time to happen. So giving time for those platelets to stick together, giving time for coagulation to kick in. So this can reduce blood loss for anywhere between several minutes to several hours, depending on the size of the vessel, how big the stimulus was, how much we're contracting. So allowing all those other mechanisms to come into play. We have a platelet plug formation where the platelets stick together and form a plug. So this is going to do two things for us. One, it does temporarily block the hole because they're all stuck together and they're in front of that hole. So it's going to help lessen fluid loss through that opening. But the real reason we want to stick together is because it activates the platelets. Platelets are like little kids, right? We've all seen little kids. Okay? When they're at home, they're nice, quiet little guys. What happens when you take your kids to Chuck E. Cheese?
They become a wild little animal.
Crazy children, right? You can have the perfectest little angel. You go to Chuck E. Cheese and they're going to run around screaming and yelling just like all the other little heathens that are out there. So again, it doesn't matter if you're serving carrot sticks or pizza and ice cream at that birthday party, they'll go crazy because there's other kids present. So they have ability to go crazy because there's a bunch of them. Same thing with platelets. By themselves, they're unassuming, they don't cause any problems, but when they all stick together, it changes them. So they start releasing that serotonin, they start releasing that ADP to kickstart that next phase, that coagulation phase. So the more we stick together, the more serotonin we release, the more PF3 we release, the bigger the response we're gonna have. Just like the more kids at Chuck E. Cheese, the crazier it's going to be, right?
The happier we'll be.
No.
They're not happy. It's crazy. That's why back in the day when I had little peoples, we'd go to Chuck E. Cheese like as soon as they opened because pizza was fresh, and then they were testing machines, so free tickets, and there was like 2 kids there. So and they still got to play their games, and mom got to save money and got to play on the Terminator. I love the Terminator game. Right? Anyway, so after 1 o'clock it gets crazy there, right? A little dicey. Don't want to go back. So what is going to help those platelets stick together is platelets will stick to things that are rough. Now, normally the inside of blood vessels are very, very smooth, like a water slide. And just like you going down a water slide, you're not going to stick as long as there's enough water keeping everything going. If there's no water, you stick, it's uncomfortable. That's what's going to happen. If we rough up the area, the platelets are going to stick to that rough area. So how we make it rough is we damage the blood vessel. So when you damage an artery or a vein, there is connective tissue around the outside, and collagen fibers are rough. So the platelets start sticking to the collagen fibers, then they start sticking to each other, and they just build and build and build. So anything that makes the inside of that blood vessel rough can kickstart a platelet plug formation. This is how some people will have clotting disorders even though they don't have an injury. If they've got a rough spot on their blood vessel, maybe because fat's on the inside of that vessel and the platelets stick to the fat and then they stick to each other, then they cause a blood clot. So anything that roughs up that vessel is going to cause something or be able to be a foundation for those platelets to stick to and then kickstart the whole reaction. So here's our vascular spasm with my favorite artist who always draws the weapons in so you don't just think it randomly broke. Cleaved it in this case. So vessel spasm. And then of course we have the platelet plug formation. So once you cut through that vessel, again, you're going to have your outside of the blood vessel is going to have dense irregular connective tissue with lots of collagen fibers. You're going to have some areolar connective tissue underneath the endothelium for support. That has collagen fibers. So if we stick to those collagen fibers, we start sticking to that, we start sticking to each other, then we release a bunch of chemicals and go crazy to allow for coagulation to happen. So coagulation, blood clotting. There are over 30 different substances involved in blood clotting. This is why clotting disorders can be difficult to treat, because if you have a problem with one of the 30, then you're not going to clot properly. And then they have to figure out which one of the 30 is causing the issues. And this is why sometimes when people have clotting disorders, they just give you whole blood. It's like, yeah, there's something wrong with you. We'll just give you everything and hope for the best. So in this case, sometimes it's just one factor that's off. It might be 2 or 3 factors that are off, depending on the type of clotting disorder the person has. Now we can kickstart clotting 2 different ways, either within the bloodstream or on the outside of the bloodstream. So within the bloodstream, it is intrinsic. This is when we have that platelet plug formation and the platelets release PF3. So the platelets, the blood, have started the coagulation process. Extrinsic, outside of the blood, in this case, this is when the tissues release tissue thromboplastin. So again, when you have injury to a site, these cells aren't just going to sit there and take it. They're going to release chemicals that are going to announce that they've had an injury. And those chemicals, again, are going to be involved in chemotaxis. That way it attracts white blood cells to the area so we can fight off infection. And the chemical of tissue thromboplastin will cause again, kickstart of clotting. So hopefully we patch a hole if there happens to be a hole. So the tissues can complain. and kickstart the clotting process, or the blood cells, the platelets can complain and kickstart the process. So here's what it looks like underneath a microscope. You have the fibrin, so those fibers that form the net that catches the red blood cells, kind of like a fishing net that catches fish. And the more red blood cells we catch, the fuller the net gets, the more things are going to block the opening. And we hope to catch tons of red blood cells because they're going to form little barriers, all trapping that blood within, so they can't escape anymore until we clog up that opening and form a scab or a blood clot. So here's a couple of red blood cells that have been caught in the fiber net. Here's a white blood cell who got caught, and you can see his major histocompatibility antigens, his little fuzzies all over it so they can identify cell. So coagulation, whether we have tissue thromboplastin or platelet factor 3, so PF3, both of them are going to get us to what is called factor X, which sounds cool on paper. It's factor X. It just means the 10th factor they discovered because it's Roman numerals. So depending on where we're going, the extrinsic, here's your tissue thromboplastin, has to combine with calcium and several factors to get to factor X. If we are the intrinsic, we're releasing PF3 along with calcium and different clotting factors that get us to factor X. Okay, so we're not going to go detail with both of them. Again, you could probably take an entire class about coagulation where they get super detailed with everybody. But we do have to have all of these parts. So if you're missing factor 7, if you're missing factor 10, you're not going to be able to clot properly. And you have to have the right amount of calcium. So again, calcium necessary. We learned in A&P1 for muscle contraction, final trigger. We learned that it's necessary for neural tissue to release neurotransmitters, obviously necessary for strong, healthy skeletons. But we also have to have it for blood clotting. So that's one of those things that could happen if you're depleted of calcium. Not only would you have muscle problems, nervous tissue problems, you would have bleeding problems as well. And that's one of the early signs is bleeding issues. You bleed too much, even before the muscles and the nerves start complaining about loss of calcium. So we're going to get to this factor X. And again, we have to have the calcium along with whether it's PF3 or tissue thromboplastin. And that's going to take our prothrombin activator. They're just calling it prothrombinase, which is the enzyme form of that. And that's going to turn any prothrombin in the vicinity into thrombin. Prothrombin is a type of plasma protein. It's part of the 1% that we didn't discuss because there's a lot in that 1%. That's going to convert prothrombin into thrombin. And thrombin can then be converted into fibrinogen on the fly, because even though we make fibrinogen, it's 4% of our plasma protein, we're not guaranteed to have enough on site to form a good blood clot. We'll probably run out. So we need to have reinforcements on site. And that's where the thrombin and the prothrombin come into play. They give us a big burst of fibrinogen. And of course, if we remove the ogen, the safety form, from the fibrinogen, we end up with fibrin. And it's those fibrins, those little fibers that catch the red blood cells, catch the white blood cells, and so forth, forming that clot. Same thing, just without the blood vessel in the background. So again, we have the extrinsic with our tissue thromboplastin on this, in the sciencey row. They just call it factor 3 because tissue thromboplastin's a really long phrase, along with some calcium, get us to this point. Or the intrinsic, where the platelets are going to release PF3, that's going to kickstart some reactions along with calcium to get us to this point. And again, factor X will turn prothrombin activator and allow that to convert prothrombin into thrombin. And thrombin can be converted into a lot more fibrinogen on site. And then, of course, we're going to remove the safety, giving us fibrin. And then we're going to be able to start catching those red blood cells, forming that net to clog up the opening. And of course, we're going to continue to need a lot of things. Calcium is necessary at several checkpoints. So if we start calcium here and we run out before here, we're not going to clot properly. We continue to utilize PF3 to encourage, so the platelets aren't just done when they're up here, they're continuing to contribute to that clot formation. So the more platelets that stick together, the more PF3 we release, the stronger the response is, the bigger the clot is going to be. Okay? So again, if anybody is missing, we'll have problems with clotting. So if we take out calcium, we'll have problems. If we take out factor 8 or 9 or 7 or any of them, we'll have issues and we won't be able to clot properly. One of the big ones that you can take out is prothrombin. And this is one of the clotting or anti-clotting clotting or coagulation medications do. Okay, so if you are on warfarin, it takes out prothrombin. Okay, that's gonna hit down here, so it's gonna prevent you from clotting, and that's how that drug works. Okay. And this is really just needs to be taken out, but it just kind of shows you our whole scab formation. Talk in depth about that in A&P1. So not only are those platelets releasing PF3 to keep the whole clotting process going, they're also continuously releasing serotonin, helping the capillaries constrict because the capillaries can't have a vascular spasm. They also help the veins to constrict a little bit better, as well as the arteries. So keeping the hole smaller so we can patch it. Once the patch is in place, even if the vessel relaxes, everything's kind of stuck together. So we're not going to have that leakage. Now, as mentioned, prothrombin is a blood protein that is synthesized by the liver. So this is one of those proteins we would be missing if we started having liver failure. That's why one of the early symptoms of liver failure is problems with your blood clotting, because we're not able to make fibrinogen, we're not able to make prothrombin, so we can't clot properly. Now, in order to make prothrombin, you have to have vitamin K. Okay, so in case you've ever wondered, why do you need vitamin K? It's so you can make prothrombin. That's its big play in the body. As mentioned, fibrinogen is a blood protein also synthesized by the liver, 4% of our plasma proteins. Now, blood serum, sometimes you'll see this term used either in medical testing or in drug applications. This is the liquid that remains after we remove the clotting proteins. Basically, it's the blood plasma minus fibrinogen. So blood serums used to be what some vaccines were delivered as. That was kind of the chaser for the vaccine. You can still see blood serum used in certain testing. So they'll talk about blood augers and things like that in microland. So this is something that we still use, even though we don't usually use it as a vaccine component. You still can see some of this still used in science. Yes, ma'am.
If you take an SSRI, does it affect clotting, or does it only function as like a neurotransmitter agent?
That is an excellent question. I don't know what that is.
A selective serotonin reuptake inhibitor.
Oh,
Antidepressants.
you so fancy.
Yeah.
Usually the serotonin that is released at the site is so localized that circulating isn't going to cause a big issue.
Okay.
So with that one, you're looking at it suppressing the neurotransmitter release versus being in the vicinity when a clot is starting to happen.
Okay.
Now, obviously, if you have really, really high doses, there's a chance that it could influence it, but not as much as something like Plavix or anything along those lines. You got to be at the right spot to stop them. And even if you could stop the the serotonin just makes the hole smaller. It would just take longer for you to clot because you'd have to build a bigger clot. So it's not going to completely stop you from clotting. All right, so factors that oppose clotting. So first ones, again, those endothelial walls. Endothelial walls are very, very smooth, again, just like a water slide. So nobody should be sticking to it. And if the platelets can't stick to the capillaries, they can't form a plug, they can't release PF3, we're not going to kickstart that coagulation process. Now, one of the things that helps them to be so slick, not only are they physically smooth, but they also have an electronegative charge. They're negatively charged. Platelets are negatively charged, so they should repel each other. So the only thing that allows them to stick is if you have a rough spot or something that negates the negativity of that vessel. So if you have a chunk of fat, that chunk of fat might be sticky, so the platelets might stick to that guy, causing clotting problems. Or that fat, again, isn't negatively charged, but it can neutralize the negativity a little bit, allowing for stickage. Okay? It's one of the reasons why we don't want fat coating everything, because it's going to interfere with our blood flow. Heparin. Again, heparin is one of those chemicals released by our basophils. It's actually a polysaccharide. It's a really big sugar that is going to be released, and it prevents thrombin from converting fibrinogen into fibrin. So whenever we have heparin release, heparin is going to stop this stage right here. Okay, so it's going to start the whole process, but it's not going to be able to form that net. If we can't form that net, we're not going to be able to clot properly. So again, this is what our basophils are going to release, and this is what our mast cells are going to release. So it sounds counterproductive. If you have a hole, you want to patch the hole, but you don't want to patch it too soon because you want other things to get there. You want antibodies to show up. You want other white blood cells to show up. You want the army, so to speak, to show up so you can fight off infections. If you close the hole too quickly, they're not going to show up. They're not going to mobilize. Okay, so it's going to take give a little bit of a lag so we can mobilize our defenses. Warfarin or Coumadin, these two are interchangeable. They're going to block vitamin K. Okay, so they're going to go to the liver and prevent the liver from utilizing vitamin K to make prothrombin, and of course, then it's going to cause issues with clotting. And this is why this is one of those first drugs they used to use to help prevent clotting for individuals. And if you watch enough of those commercials about it, they're like, this drug doesn't take all the liver testing warfarin does. Warfarin, if you're on that, you do have to do frequent liver testing to make sure, yes, we're blocking the liver from producing prothrombin, but we don't want to block the liver so much that you die or something. So you have to be very careful with those medications that alter the functionality of the liver, because it can alter the functionality of the liver in the extreme, which can cause health issues. Warfarin is also the active ingredient to decon. So in case you wonder how decon kills mice, they bleed to death internally. Now, the mice, rodents, whatever, have to eat their weight in warfarin. So that's why it takes a while for decon to work on your mice, and it takes longer to work on your rats, and a really long time to work on your neighbor's dog. Don't do that, because you'd have to eat your body weight in warfarin in order for it to work. So if your neighbor had a 100-pound dog that was annoying, that's 100 pounds of decon. There's cheaper ways to get rid of neighbor dogs, right? Not that you're going to do that. Call it in or something. That's a lot of waste right there. Because you do have to eat close to your body weight for it to be deadly, this is why you oftentimes don't have to worry if your kid finds the decon. Now, other rat poisons work different ways, but decon does this. So if your kid has ever found the box, if you call the poison control, they'll ask you, are they bleeding excessively? Look at their gums. Are their gums bleeding? Gums are very thin, so they're the first things to bleed if you have a clotting disorder. So if your kid's gums aren't bleeding, you're okay. But if they are bleeding, you should take them to the emergency room because they ate enough of the boxes to cause an issue. But again, it's going to be filtered out, processed out very quickly. So you don't have to worry too much. Anybody else worry?
What would they do if the ER if they did eat a lot of it?
They would give you the countermeasures to warfarin.
Okay.
So vitamin K, make sure your liver's functioning okay.
Okay.
Transfusion if necessary. So that kind of stuff. And it doesn't do any other issues. I ate decon as a kid. That's not why I'm the way I am. I have other issues. My mom's like, you had a fork and everything. I was like, classic. My little one ate decon. He crawled under the couch for that thing. He's like, stop it. He's fine. So as long as you don't bleed to death, you're okay. It's not going to cause neurological damage or anything like that. Okay. Aspirin. Now, aspirin, again, oftentimes we hear it say it thins the blood. It doesn't change the viscosity of your blood. That's not what aspirin does. Aspirin's in your NSAIDs. This includes ibuprofen and Advil and Aleve. Basically, all the drugs they tell you not to take before surgery. So if you've had surgery before, usually about a week or 2 weeks ahead of time, they're like, you need to be off your Plavix, you need to be off aspirin therapies, you need to be off of anything but Tylenol because you can bleed out. If you have a lot of dental surgery to go do, they'll tell you to get off those things so you don't bleed like crazy. So what aspirin does is it prevents platelets from sticking. And if platelets can't stick together, they can't form a plug, they can't release PF3, you don't clot. So it doesn't change the viscosity of your blood or thin your blood, it prevents the sticking. So if we can't stick, we can't clot. So that's why you bleed more when you're on aspirin therapies or anything like that. Plavix is just like super aspirin. So if you are on Plavix or you know people who are on Plavix, the doctors usually won't tell you, but the vets will. Take sugar with you. Sugar will help you to clot faster. So if you have an open wound, you pour sugar on it. One, sugar is antibacterial. Bacteria can't grow on sugar. That's why gummy bears can last forever in your car because nobody will eat the gummy bear. That's disgusting. Sugar is rough at the molecular level and at the cellular level. So being rough, platelets will stick to the sugar. And if you get enough platelets sticking to the sugar, it can trigger them to release PF3, allowing for clotting to happen. So we've got sterile, we've got sticky. And then of course, being sugar, it gets dissolved and used as sugar in your body. So it's something that your body can use to fuel activity. So people who are on Plavix should be advised to carry packets of sugar around with them. So if you get a little cut, paper cut, whatever, you can pour sugar on it and it'll clot a lot faster. So again, a lot of times your doctors and nurses won't tell you, but if you're around vets, especially big animal vets, they're like, keep sugar in your barn. That's going to help with blood clotting. So same thing with people. So if you're on any kind of blood thinners, swipe those little packets of sugar everywhere you go. So that way you can slow up blood and allow it to clot properly. Okay. Streptokinase, this is an enzyme because it ends in ACE that is going to digest fibrin. And if we break up fibrin, we're going to break up the blood clot. So this is one of those drugs that they used to use as a clot busting drug back if you had a stroke that was caused by a blood clot or a heart attack that was caused by a blood clot or just a random clotting disorder and a clot formed in somewhere in your body. Now, the unfortunate thing with streptokinase, it is non-specific. It'll dissolve any protein. So on the way to the clot, it's going to break down anything it comes in contact with. So oftentimes it has to be administered at the hospital underneath care. That way we don't break apart other parts of your body. Now, you don't see streptokinase very often in American hospitals because now we have better stuff. But if you're a part of Doctors Without Borders or you go, do mission work and stuff like that, you'll still see streptokinase in third world countries and stuff like that because it's a cheaper drug, easier drug for a lot of those areas to get a hold of if they can't get a hold of the good stuff. Now, the good stuff is TPA. Okay, so tissue plasminogen activator. So this one is genetically engineered. So again, when they say GMOs are evil, let them bleed to death on the side of the road because they don't need any TPA because it's evil. People that don't like GMOs just make me want to twitch. Anywho, so genetically engineered to break apart clots, not all the proteins in the body. So this is what they use now, again, if someone's having a heart attack or stroke that is caused by that blood clot. So it's going to go in there, bust up the clot, open up the blood vessel, so hopefully your brain doesn't die or your heart doesn't die. So it's faster than streptokinase, and it's more specific than streptokinase because it's not wasting its time trying to break down all the other proteins in your body. So it's safer to administer and is more efficient. Now, anytime you're giving those, again, you're in the hospital setting and they're going to monitor to make sure everything's okay and you're not having weird side effects to the drug or anything like that. Citrate and oxalate salts. So these two chemicals remove calcium from the bloodstream. And if you remove calcium, you can't clot properly. So oftentimes these are administered to people who have been having a stroke or a heart attack. They just busted up the clot. They don't want you to have a secondary clot too quickly. So they're going to give you this for the first 24 hours or so you don't reclot, so you don't have a second stroke or a second heart attack fairly quickly. Now, citrate oxalate salts are destroyed by the liver. So they're only going to circulate for a little while before the liver gets rid of them. So again, this is usually administered on site to make sure that you don't have those secondary clots while you're in the hospital. Coagulation test, bleeding time. You just stab somebody and watch them bleed. They call it science. So a pierced fingertip usually bleeds for about 2 to 3 seconds. So a good piercing, not just like a little grazing paper cut or something. So bleeding time increases with pernicious anemia. If you have any form of anemia, you're going to bleed longer because you don't have as many red blood cells. So it takes longer to capture enough in that net of fibrin to block the hole. So that's one of the downsides of anemia that isn't as glorious as the not carrying oxygen thing, but you'll have bleeding times increase. Acute leukemia, because that often contributes to pernicious anemia. Thrombocytopenia, not enough platelets, those can increase bleeding time. Coagulation time, again, we learned this one in the lab. So you take blood in that non-herpetinized tube. So again, it doesn't have the gunk at the bottom to keep blood liquidy, which is just heparin at the bottom of those tubes when you draw blood for blood testing. So you put them in a naked tube and let the thing clot. So it takes about 3 to 6 minutes for the average. Blood platelet count, where they count your platelets, obviously. So you have anything below 150,000 per cubic millimeter, normal coagulation will not occur. We won't have enough to form a big platelet plug to release PF3 to kickstart the intrinsic pathway. And then prothrombin time. This is the only one that you have to alter the blood. So all these other ones, you just, watch them bleed, watch it clot, count their cells, no altering necessary. This one, you have to send it off to the lab and alter the blood before you test it. So this is to see how much prothrombin you have. So again, if you're on warfarin or any of those vitamin K suppressants, you're going to be doing prothrombin times to make sure that they're suppressing it enough, not too much, not too little. So typical prothrombin time is about 12 to 20 seconds. That means it's going to take about 12 to 20 seconds to go from this point to this point down here. Okay, so that's a fairly quick run on those reactions. So what we do is you take that blood sample and you add citrate or oxalate salts. That is going to strip the calcium out of it. Then you add back a known amount of calcium and a known amount of tissue thromboplastin. That allows you to figure out prothrombin. It's kind of like if you have A and B, you can figure out C on a triangle. Okay, so by adding this much calcium to this much tissue thromboplastin. If it takes this long to get to thrombin formation, we know that there's this much prothrombin in the bloodstream. If it takes longer, there's less. If it takes less, then there's more. So they can use that to figure out how much prothrombin we have if the warfarin is working or the vitamin K blocking is working. So thromboanalytic disorder. So a thrombus, that is a stationary blood clot. So this is both a good and a bad thing if you have a disorder, because with it being stationary, you know exactly where it is, so you can target it and you know what's going to be happening. It's like you're blocking this vessel, that means blood can't get past that point. You know what tissues are going to be in the immediate danger of that blockage. Now with an embolus, this is a wandering blood clot. That blood clot is flowing through your bloodstream. This one is a little bit more problematic because you know it's going to get stuck in the first small vessel it comes across, but you can't always predict what is that small vessel is going to wedge itself in, or what is the speed at which it's going to wedge itself. So it can cause more damage because you have to wait to see where it's going to see how it's going to kill your patient. So big ones are things like pulmonary embolism. So when you get a pulmonary embolism, you have a blood clot, often starts as a blood clot in the leg. Okay, so in the venous system in the leg itself. And of course, once it breaks free, it's going to flow in the bloodstream until it gets to the first small vessel. And of course, being in the veins, we get bigger and bigger and bigger as we get to the heart. As we go through the heart, the first small vessel we hit happens to be the pulmonary arteries. And there's enough force of the heart pushing against the backside of that clot, it's going to blow out your lung tissue. So you'll end up bleeding in your lungs and drowning in your own blood. So that could be a very awkward way to die. This is why they always worry about blood clots in the legs, because this is what they end up causing whenever they do break free. So this is why there's a lot of the regulations. You can't go diving and flying in an airplane within so many hours of each other, because the pressure changes from diving versus being up in an airplane can cause a blood clot. This is why they tell you to get up and move around frequently so you don't get blood clots, even on airplanes which have long flight times. They'll tell you to walk around the cabin a little bit. It's notorious just because of pressure changes in the atmosphere that can cause blood clots in your legs. So that's the one that usually gets to people. They're like, and they walked off the plane and dropped dead. You're like, yeah, that's what the pulmonary embolism does. This kills you quite quickly once it breaks free and lodges in your lungs. So those are the ones that they always worry about. Ooh, blood groups. So again, when we look at red blood cells, they don't have the major histocompatibility antigens because they don't have a nucleus to build those cell structures. But what they have, again, are going to be their own group of antigens, so we can do blood typing. Now, an antigen is a glycoprotein. It's a combination of a sugar and a protein that is genetically determined. So your DNA tells you how to build the sugar. And those antigens are on the cell membrane and stick out into the cytoplasm. And that is how we can recognize cells. So again, a white blood cell is going to bump up against an antigen. If the antigen appears familiar, they're going to leave it alone. If the antigen appears foreign, they're going to kill it. Now, again, our red blood cell antigens are general enough. This is why we can get transfusions easier than we can get organs donated, because we don't have the same antigens, and blood antigens are not as specific as the major histocompatibility antigens that we see on other cells. Now, there's actually 50 different types of antigens for red blood cells. So we only have to know the top 2 for lecture. And of course, in lab, we know the top 3, right?
Exactly.
And if we don't, we should within like 45 minutes. So we're going to care about, the A, B, and O group, the RH factors. And in lab, we also add in the M and Ns to that. Now, A, B, and O is going to be the most prevalent. That's the one most people know about. So you're either type A, you're type B, type O, or you're type AB. So there's A antigens, there's B antigens, and there's naked no antigens. That's where you have your O's. So there's not an AB antigen. It's A and B associated. So here's just showing you those antigens. So we have O, it's naked. That means this little guy doesn't have anything coming off of it to touch anybody. Then we have type A that has that's galactosamine, so a little protein. We have B that has galactose, and then if you have A and B, you have both an A antigen and a B antigen sitting out there. Okay. So again, type A, type B, type AB has both antigens. Type O does not have either one of those. Now, of course, the antigens are something you were born with. They're going to be on your cells as soon as you make cells. And the antibodies are going to kill the antigens. So you're always going to have antibodies in your plasma that kill not you. So if you're type A, you're going to have antibodies to kill type B. So that means you're going to have the beta antibodies or the B antibodies. If you're type B, you have the B antigen, which means you're going to have the antibodies to kill A. So you're going to have the alpha or the anti-A antibodies. If you are type O, you don't have A or B, so you actually have the antibodies to fight off A and the antibodies to fight off B floating around in your bloodstream, which is why O's can only get O's. If you give them A or B, they'll die. And then, of course, if you're AB, you have both A antigens and B antigens, which means you have no antibodies because you're not going to attack self, which is why people who have AB blood can take anybody's because they're not going to react to anybody's blood that comes in. And that's the point. So here's our type. So here's our type A with their little A antigens and their anti-B antibodies. So circles versus triangles. Here's our B with our B antigens with our little triangles and our anti-A with the circles. Type AB has A's and B's, no antibodies. Type O is naked, so it's going to have stuff to kill the A's and stuff to kill the B's. So what happens with these antibodies? Antibodies basically bind to antigens, so either they could rip apart the cells or it signals to white blood cells that, hey, look, here's a bunch of mess we need to get rid of. So it will attract white blood cells at some point. Now you're going to have this, everybody sticking together with the red blood cells. This is called agglutinin or clumping of your red blood cells. Now, agglutinin or clumping is not the same as clotting. So clotting is normal. Clotting is kickstarted by platelet activity to form a blood clot. Here, there's no platelets, there's no fibrinogen, none of the stuff that we just got done looking at. So clotting, completely different thing than clumping. And so try not to get them, even though they're both having red blood cells stick together, they have a different catalyst for that. There's a net versus everybody tangled up together with antibodies. Okay. So our percentage, again, O is the most common because O is the ancestral form for humans. So 45% for Caucasians, 49% for African Americans. A is your next most common. It is the mutation most associated with European. So 40%, 27%. B is the lower mutation, the more recent mutation. So 10% versus 20%. And AB's 4% across the board. So harder to get the AB group. RH factor. So again, RH factor was first discovered in rufous monkeys, and then they found it on humans, and that's where the RH is coming from, is from that reference to how it was first discovered. So if you have RH factor antigens, you're going to be positive, just like if you have COVID, you're positive for COVID, or if you have AIDS, you're positive for AIDS. So positive means presence of antigen in this case. If you are negative, you don't have the RH factor. You don't have that antigen. Now, the big difference between the RH factor and the A, B, and O group is there's no naturally occurring antibody. So if you are negative, you don't have the antigen, but you also do not have the antibody. And that's why negative can give to anybody, because they can give to positives because they don't have an antibody, and they can give to negatives because they don't have an antibody and the negatives match. So percentages, RH positive is the most common, 85%, 95%, RH negative is 15 and 5%. So the negatives are a little bit harder to find than the positives. So how do you get an RH antibody? So how do you become sensitized medically? So you have to be exposed to positive before the negative can fight it off. It's just like, how can you develop antibodies to fight off the flu? You get a flu vaccine. That introduces your body to the flu, and then you can make antibodies to kill the flu. Same thing here. So it's just like how a vaccine works. Whenever you have somebody who's Rh negative and you give them positive blood, that blood cell that they're getting has the Rh factor. The body doesn't recognize it because they don't have that. And they're like, what is that? I don't know what it is. It's not self. And if it's not self, we've got to kill it. So when they're exposed to that positive blood, their body is going to start making antibodies to kill the positive. Okay. And of course, once they have those antibodies, they are now said to be sensitized. If they are sensitized, there usually is a big something on their medical folder, red folder, something to indicate, because the next exposure will be fatal. Okay, so the first one is your freebie. The second one will be fatal for that individual, because if you get exposed to positive for a second time, your antibodies to fight off positive will now attack any blood that comes in, and then you're going to have that transfusion reaction. Once you are sensitized, you can't give anymore, because you can't give blood to positive people because you'll attack positive people's blood, and you can't give blood to negative people because then you'll sensitize that negative person. So once you become sensitized, you're off of the list for blood donations and organ donations and stuff like that, because you're going to kill the people that you're trying to save. Okay, so hopefully you don't get sensitized. Yeah, it's a good way to lose your job if you're a nurse, right? Here, have some blood. So that leads us to our issue with children, because, kids. Erythroblastosis fetalis, also known as hemolytic disease of the newborn. So back in the day, before people got married, they oftentimes had to have a blood test. So up through the 80s, in many states, you had to have a blood test before you could get married. And it wasn't to see if you had syphilis or cooties that you could give your spouse. That's a different business. What they were checking for was RH. Okay? And that's because if you are a negative woman, RH positive is a dominant trait. So if you marry a positive male, the odds are your kids are going to be positive. And that's going to expose the mother to those positive antibodies. That is going to sensitize the mother and eventually kill the offspring. So if you do not get any medical intervention, you're going to have one normal pregnancy, and then everything else is going to be a fatality for you. So back before birth control was available, back before medicine was available to try to prevent this condition, this would have people having one child that was healthy and then having multiple miscarriages, or children who were born dead or defective, and they were have to, if they survived, they were sent off to a loony bin, because that's what they used to do back in the day. So they would tell women if they were negative, they're like, how much do you really love your guy? Do you love him enough to have one healthy pregnancy and doom the rest of your children to death? It was kind of a big deal back in the day before we got medicine to prevent this condition from happening. So yay for medicine. So RH negative mother having an RH positive fetus. So again, red blood cells last about 120 days. Pregnancy is longer than 120 days. So that means towards the end of the pregnancy, baby blood cells are going to naturally break down and get recycled. And of course, part of the job of being a mom in pregnancy is to get rid of baby waste. So even though the red blood cells would be broken down, if any of those RH factor molecules survived passing through the placenta, that would trigger an immune response. And this actually happens all the time. Women are mildly allergic to their pregnancies. Some women are more so. That's why they have miscarriages. It depends on how tolerant your immune system is. But if you had any of those positive RH factors cross the membrane, mom's system would be like, ooh, what's that? I don't know. I'm going to kill it. So they would start making antibodies. So towards the end of the pregnancy, that first pregnancy, mom would be sensitized. She would start making antibodies that would kill positive. Right? Now, the first baby, again, is your freebie, because you don't make enough of those antibodies during that pregnancy to cause any kind of fetal harm to that first baby. Now, unfortunately, once mom is sensitized, she's always going to make those antibodies. And the job of mom is to give antibodies to her baby to help protect her baby. So that second pregnancy, those antibodies would cross the placenta, get to the baby. And if that baby was positive, mom's anti-positive antibodies would start attacking the baby. Okay, so you would have that problem with the second pregnancy rather than the first pregnancy. So during that second pregnancy, when that anti-positive antibody goes through, you're going to start having the agulation of the baby's red blood cells. It's a transfusion reaction without the transfusion. So that's going to cause the red blood cells to get destroyed. So in order to keep functioning, that baby's going to need more red blood cells, so they're going to amp up production. So in order to make more red blood cells, the liver and the spleen and the bone marrow are going to all ramp up production, and that's going to cause the liver to enlarge. It's going to cause the spleen to enlarge, and they're going to be pumping out lots and lots of red blood cells to replace everything that we've lost. Now, unfortunately, with those red blood cells, if you pump them out too quickly, they don't lose their nucleus like they're supposed to. They don't become a normal reticulocyte and then a normal red blood cell. You end up with erythroblasts, nucleated red blood cells floating around. And again, we have to have them anucleated so they can be that proper shape, so they can bend and twist to go through small vessels, so they can stack properly. So if you have a whole bunch of red blood cells that have a nucleus, one, they have less hemoglobin, so you're going to have that problem with carrying oxygen. But two, since they're soccer balls instead of frisbees, they're going to get wedged in tiny capillaries, blowing out capillaries, causing more damage to the blood vessels as well as to those red blood cells. So that's where the erythroblastosis comes from. So we have lots and lots of red blood cells with nuclei floating about. So by the time the baby is born, because mom's antibodies have been given since day one of the hookup between the placenta and the uterus, the baby has been going through essentially a transfusion reaction for months. Okay, so by the time they are born, they are severely anemic because most of their red blood cells are destroyed fairly early on. They have severe jaundice because their liver is not used to dealing with all the work. They have that enlarged liver and spleen. And the excessive amounts of bilirubin, because of the breakdown of the red blood cells, can lead to a secondary condition called kernicterus. Kernicterus is the fatality causing one. So jaundice can cause fatality over time because of liver failures and such. But it's those high levels of bilirubin that causes the neurological damage that we associate with this condition. So kernicterus is a syndrome where we have such toxic levels of bilirubin, it starts killing off neural tissue. And if we kill off the brain, of course, if it affects the sensory area, the baby can be born blind, they can be born deaf, they can have issues with other senses. If it hits motor areas, they can have partial paralysis or complete paralysis. If it hits the thinking areas, they're going to have issues with thinking. So this, again, if your kid did survive, there was a good chance that they're going to need a lot of medical help, either because physical problems or mental problems for those individuals. So motor, sensory, mental deficiencies, and it could kill the baby outright. Okay, so again, one good pregnancy, the rest of it is going to go downhill from there. Now, if a baby is born with that severe jaundice, what they're going to do to help them out is phototherapy. So UV light destroys bilirubin. So this is why when you have a baby, usually the first couple of weeks, they'll tell you to take your baby outside a whole lot, get a lot of sunlight, especially if they're slightly jaundiced. Now, a lot of babies are born slightly jaundiced. And that's because they're used to mom getting rid of waste versus the liver having to do its job. So having a slight yellow is okay. Again, take them outside, get some sunlight, breaks down the bilirubin so we don't have health issues. In this case, the jaundice is so severe, just normal light isn't going to do it. So they do the phototherapy. Basically, it's like a little baby tanning bed with little goggles and everything, and they tan them every day. So it looks adorable. It's tragic, but you're like, they make tiny tanning beds. So that's going to help try to prevent kernicterus. If you can get them past the point, if the brain doesn't get damaged, eventually their blood cells will form normally and they're not going to get destroyed on a regular basis. So it may take a few months, but your baby can come out of it if we don't have the neurological damage. So again, not a good prognosis for women who have that negative for their RH. So we have made drugs to help prevent this from happening. So Rogan, Gandiolin, there's a lot of other versions out there as well. So what it is going to do is prevent the mom from making antibodies, because if we can stop her from making antibodies, she won't send those to her babies and it won't kill the babies. So this is given in the last 3 months of pregnancy, because again, by then the red blood cells have started to recycle from the fetus. You're going to get another big dose during delivery. Because even though mom blood and baby blood are separate, during delivery, their placenta is going to be ripped off of the uterus. There could be bleeding from the placenta, from the uterus. So there is that exposure there. And in sometimes a couple of days after that delivery. So this drug is twofold. One, it destroys the fetal red blood cells. So hopefully if we destroy those cells, they won't have any antibodies to trigger mom. And it's also going to go to mom's system and suppress her immune system. So she thinks she's got antibodies, so she doesn't need to make antibodies. And this is something that's going to be given with every pregnancy. So if you are negative and you want to have 10 kids, that's Rogan 10 times to make sure that you don't end up being sensitized and you don't end up having babies that have the fatality issues. This is also given with an abortion, whether it's early or late term, because anyway, you're going to have carnage of baby being ripped apart. So you're gonna be exposed, and of course miscarriages, especially early on, because you're gonna reabsorb and process out. So you're gonna be exposed to those RH factors. So every pregnancy, even if they're not successful, you're gonna have to take RhoGAM associated with it. So here's our picture form. And again, for whatever reason, they don't draw happy people in your textbook. They're all depressed. So she's even pregnant and depressed, but you know, they did let her get a new haircut, put some hair braided, you know, something to pull back her hair. And they did make her gain twice as much weight with the second pregnancy. How accurate of that? It's like, that's not right. But anywho, so first baby positive, mama negative. She's exposed to the RH, so she's going to start making anti-RH antibodies. And again, now that she's sensitized, not only is that going to affect her pregnancy, she can't give blood anymore because it's the same issue. So negative women who have had positive children have to be checked to make sure if they have been sensitized and if they can give blood or what have you. And then of course, second baby is going to get those antibodies, and the second baby is going to have the health concerns and possible fatality. So just give mama the RhoGAM, and then she's not going to have that. Big bad hair question? Cross matching. Now, of course, if you've got plenty of time, you're scheduling surgery, you'll usually go in about a week before surgery, giving your blood testing so they can match you as close as humanly possible and have that blood available in case you need it during the surgery. But of course, if we have, again, an emergency, they can't do major cross matching because, you know, it's an emergency. Give them a bag of blood right now or they die kind of scenario. But if we're able to, we're going to test it against it. Up to 50 different antigens to make sure we're as close as possible. So our major cross match is looking at donor cells and recipient cells. If you're A positive, they want you to have A positive. So your cells match, and if your cells match, you're not going to attack the blood coming in from that donor, and that donor's plasma shouldn't attack your cells because y'all are matchy. Again, the universal donor is O negative because even if you are type A, if you're receiving O negative cells, O doesn't have any antigens on it, so there's nothing for your antibodies to attack as you receive this O blood. So that's why we do it that way. Universal recipient, again, AB positive because you don't have any antibodies against anything because you've already got everything. So you can receive anybody's blood. Okay. Minor cross match, this is donor plasma and recipient cells. Now, again, if you're O negative, yes, your cells are naked, so the recipient won't attack the donor O cells, but that donor plasma has anti-A and anti-B antibodies because O doesn't have those antigens. So you will lose some of recipient cell when you get that. So if you're type A and you get O blood, you won't attack the O cells coming in, but the plasma coming in will attack some of your A's because it has anti-A. Now, because that donor plasma gets so diluted, it's not enough to cause a transfusion reaction or death, and losing a few cells is better than not having the blood at all. So you will lose a couple of guys, but not a whole bunch. And this is just kind of showing you that agglutinin, that clumping, where they all kind of get chunky together. And if we get the chunky, we get the clumping, we know that there's something being attacked. So they're positive for that. So there's anti-A, anti-D, that would be A positive. So what happens if you're given the wrong bag of blood? You know, other than the nurse gets fired from her job. So you're going to have agglutinin of red blood cells. You're going to have clumping because if you're type A and you're given type B, the anti-A's from the B donors is going to attack your A's, and your anti-B is going to attack the donor cells, the B cells coming in. Now, these chunks, these clumpings of red blood cells, they're going to flow until they hit a small vessel that they can't bypass. So that's going to cause temporary blockage of that vessel. Now, this typically by itself isn't fatal unless it hits the brain, and then of course it can cause a stroke. So obviously that's going to be very fatal if it hits too hard. But for the most part, we're in such tiny little vessels that these clumps will break apart. So you still have the force of the blood behind them trying to push them through that small opening. So it may take minutes to hours before they break apart under that constant pressure. Now, once we shatter those red blood cells, we're going to fill the blood with debris. Okay, so millions and millions of red blood cells are bursting forth, releasing all of their hemoglobin. And hemoglobin, again, has to be dealt with carefully. We have to manage it and break it down and carry it to the liver or so it can be excreted out as a part of bile or to the kidneys so it doesn't cause damage. So what happens is if we have all this hemoglobin that doesn't get broken down properly, hemoglobin is a very big molecule. It precipitates out. It'd be like throwing gravel into your water filter. It's going to clog your water filter. So hemoglobin concentrates in the kidney tubules, precipitating out, blocking that kidney tubule, clogging your filter. And if you clog your filter, it stops working. So if your nephrons stop working, then eventually your kidneys stop working. And if your kidneys stop working, you die. Okay? So that's what causes the fatality. It's not the clumping. It's not the destruction of the red blood cells. It's your kidney shutting down and you going into renal failure. And we know renal failure is kind of a big deal that we try to stop. So that's what is the fatal moment for that individual. Now, once they realize you've been given the wrong bag of blood, hopefully they can do it quick enough that they will put you on dialysis almost immediately. So if they put you on dialysis, that dialysis, one, will replace the kidney function so we can continue to filter out the blood. More importantly, we can filter out a lot of that hemoglobin, so hopefully your kidneys won't shut down. So if we can get you past the point of kidney failure, then you can survive. So kidney shutdown is going to take about 6 to 12 days to get to that point, get to the point that they're so clogged they're not going to work anymore. Now, hemoglobin will naturally degrade, will naturally break down, but it takes about 2 weeks. So it's going to take another few days before that hemoglobin breaks down enough that we can start flushing the system and your kidneys can start filtering again. So they're going to put you on dialysis for 2 or 3 weeks to get rid of the hemoglobin and keep your kidneys from shutting down and getting you past that point that you might have that renal failure. Now, once we've got rid of all the hemoglobin, once we've hit week 3, we know that we've filtered enough where kidneys aren't going to shut down, we're going to survive. So symptoms other than the nurse going, oh crap, you've got eukarya, you've got fever. That's because of all that toxic level of hemoglobin hitting the body. You're having a fever as a response. You get chills coupled with that fever, and then hematuria, hemoglobin in the blood, in the urine. So you start to see brown stuff coming through your urine, and that lets you know you're starting to filter that stuff. So this is just showing you again, donor A delivering to type B. Awkward. You get clumping almost immediately. Big bad hairy questions. All right. So we will finish disorders tomorrow. Oh, we gotta book it. And then we'll start the hard stuff. Woo, let's go have a practical.
Santa Maria.
Yay, practical.